Jim Moo from the GI department. The topic of my grand round today is about, I wanted to highlight some major discoveries in the field of SARS and COVID-19 research in the past 20 years. So it's a big undertaking. I'll try to stay on time. You may wonder why a gastroenterologist will be interested in COVID-19. It's going to be a long story, but the short answer is it's out of fear and out of professional necessity. I will explain more in the rest of the presentation. Let me get these. If finding the viral pathogen was the most important discovery, perhaps the second most important discovery was the viral receptors. As you may recall, SARS started in November of 2002. About a year later, in November 2003, in Nature, there was an article with the title of Angiotensin Converting Enzyme 2 as a functional receptor for SARS coronavirus. This came from Harvard University, and amazingly, they discovered an enzyme in the body that normally has nothing to do with viral infection, immune system, and infection control. It's an enzyme that regulates blood pressures. And let's take a look of the ACE2 enzyme and how it's related to what we know best. That's the ACE enzyme. In the angiotensin metabolic pathway, there are two enzymes. One is ACE1 or ACE, and one is ACE2. They're two separate enzymes. So not to confuse them, the ACE inhibitors we normally prescribe for our hypertensive patients are ACE1, not ACE2. ACE2 is the backdoor that allows the virus to invade into our cells. As you can see, ACE1 converts angiotensin 1, which is a 10 amino acid short peptide, into angiotensin 2, which is a potent vasopressor that increases the blood pressure. And by cleaving off or cutting off the two amino acids in the C terminal, and as ACE2, the receptor or backdoor that allows entrance of the virus into our body, cleaves off one additional amino acid from ACE2, from angiotensin 2, and then converts that into angiotensin 1-7. The way it's named that way is, as you can tell, there will be amino acid residues from 1 through 7 left after the enzymatic reaction. Why is this is so important to talk about viral receptors for us clinicians? Actually, once we know the receptors, we'll have a much better understanding how and why this disease behaves the way it does. Ever since the first receptor discovery, there are two more receptors found. One is TMPRSS2 and TMPRSS4. Both receptors are proteases, meaning that there are enzymes that cleaves or cuts amino acids from peptide. The reason it does that is because the spike protein needs to be cleaved into S1 and S2 in order to gain access into the body. So that's why proteases turn out to be the receptors. So with the three receptors, ACE2, TMPRSS2, TMPRSS4, how do they work together? Do they work independently, or do they work as a team, depending on each other? This study published in Science Immunology in May answers that question. It uses human enterocytes as a model, and the x-axis shows the presence and absence of different receptors. The y-axis measures the viral invasion into the human enterocytes. If you have ACE2 receptor expression alone, you do not get much infection. If you have TMPRSS2 alone, not much infection. But if you have the combination of ACE2 and TMPRSS2, you get a good amount of viral infection. You have the combination of all three, you get substantially more viral infection. So the receptors do not work independently, they work together. As we talked about, understanding of the viral receptor will give us clinicians a much better understanding of how this disease behaves clinically. One feature about these receptors is that they express on the apical surface of polarized cells. As you know, the enterocytes in the GI tract and epithelial cells in the respiratory tract, they're polarized cells. One side of the cell surface faces the lumen, the airway, or the GI tract. The other side faces blood vessels, the basolateral membrane. And the receptors are expressed on the apical surface only, which means this is not HIV, hepatitis B, or hepatitis C type of disease. It's not a blood-borne disease. It comes from the lumen. It's in the GI tract is more like hepatitis A. It's a luminal oral transmission. In the respiratory system, it's an airway transmission. If you inject the virus into the body, into the bloodstream, you probably get a totally different disease. You get endotheliitis instead of respiratory failure, probably theoretically. And then understanding where the receptor is expressed in organ and body systems will also give us an idea where this disease will attack us. It's a multi-system disorder. We know the respiratory system is involved with ACE2 expression, so we get pneumonia and respiratory failure. And what's interesting is the GI tract has the highest level of ACE2 expression viral receptor. That's why we gastroenterologists are scared to death or very concerned about GI tract involvement. And the kidney is involved. That's why a lot of severe cases have kidney failure. And the endothelial cells in the blood vessel also express a fair degree of viral receptor. That's why people get endotheliitis and blood clots and stroke and embolic events. Another phenomenon we see clinically is the disease is very uncommon or much less common in the youngsters, in the younger population. And this is our Snohomish COVID-19 dashboard as of yesterday. I'm pre-recording today, so August 13 was yesterday. As you can see, the younger population just have much less common involvement by the infection rate. Why is that? This has to do with the developmental regulation of ACE2 expression. As you can tell, in the younger population, less than 10 years old, the ACE2 gene expression level is much lower as compared to older teenagers and adults. You may not tell the difference here is huge, but the y-axis is a log scale, not a linear scale. So a little bit of difference is magnified. So we spent a lot of time talking about the viral receptor, which gives us good understanding how this disease behaves and which organ system it attacks. And let's talk about clinical epidemiology and see what kind of discoveries were made. As you may recall, back in late February and early March, when the disease took off in Washington State, we felt like we're going to be the epicenter in the US. And a lot of fear and a lot of panic. And one question we didn't know was there a large number of asymptomatic patients in the community? If so, we will all be at risk for infection. You know, patients will be coming to our office and unknowingly they will expose us, the healthcare workers, and they will expose other patients. So we were desperate for information, and very early on March 12th, just 2 weeks after the new cases starting in Washington State, the Japanese field study was published from the Diamond Princess cruise ship. As you recall, this was a disastrous cruise ship that was held off the coast of Japan, and people were not letting off. So that was a perfect small community to study asymptomatic patients. They tested between February the 5th and the 20th over a period of 15 days. They tested 3,000 people, and about 20% of them were infected by PCR testing, and half of those infected were asymptomatic. So we knew early on by reading this literature there's going to be a large population of asymptomatic patients and we will be at risk. So very soon after that, we decided in our office that all our staff should wear masks when seeing patients. So that was good information to guide our practice. And you may say, well, they're asymptomatic. Perhaps they don't carry as much virus and perhaps not as infectious. That's not necessarily true. If you look at this study published in June in Nature Medicine, very good study that compared the pink symptomatic patients with asymptomatic, the green patients for two different genes detected by PCR. The viral load were very similar. So asymptomatic patients don't necessarily shed less virus. And if you look at the viral shedding duration for the symptomatic patients, the pink color, the median 50th percentile, patients typically shed the virus for about 14 days. And then for the asymptomatic patient, the green line, they actually shed the virus 4 more days on average, 18 days. So asymptomatic patients may carry just as much virus. They actually tend to shed the virus for longer duration. Perhaps these asymptomatic patients, they develop immune tolerance. They don't fight back as much, and that's probably why they shed virus for longer. That's just my speculation. Well, we got our answer early on. There were a large number of asymptomatic patients. We need to protect our patients from each other and protect ourselves as healthcare workers. The next question, and much debated for a long time, is this disease a air droplet transmission or airborne transmission? It makes a huge difference because a droplet, you may just wear surgical masks. If it's aerosol transmission, you got to wear N95 masks. Because of the short supply of N95 masks, the government and some health authorities are very reluctant to inform the public that there's a good component of aerosol transmission. No matter what you look at, whether you're sneezing or coughing or just simply breathing, the difference between droplets and aerosol transmission is actually a continuum. Every time you sneeze, you would put out a large cloud of aerosols that are defined by its particle size, less than 5 microns. The droplets are bigger and therefore heavier. They precipitate quicker. They don't travel as far. If you look at this sneezing photograph, they use smart cameras and can capture this kind of distances travel. The droplets will and aerosols will travel as far as 6 meters, not 6 feet. That's 18 feet. For coughing, the travel distance is easily 3 meters. That's 9 feet. And then for breathing, easily 3 to 6 feet. And so after we read these articles, studies, and that shows aerosol and potential aerosol transmissions, we decided to use N95 in our GI lab. And when we made that decision, it was quite early on. We were actually able to buy it, and later it was completely out of supply. Well, that's the traditional clinical epidemiology studies and discoveries. And now this is 2020. Everything is genomic, DNA, which provides a very powerful tool for epidemiology study. And I'll give you some examples to highlight major discoveries in this field. At the University of Washington and Fred Hodge, there's a genomic epidemiologist, Trevor Bedford. He was quite active sending out Twitter messages, and this was from one of his Twitter messages. He showed this graph. The reason he showed this was the first case that came to our hospital was an imported case from Wuhan, but locally transmitted disease was not discovered until very late in February. I remember it was from high school where my son goes to. He was a part of the Seattle flu study, and accidentally they picked up, he had COVID-19. And the question was, well, could it be possible many of the so-called flu or common cold patients in the previous few months in the winter season were also COVID-19? We just didn't know. They were able to go back and check all the Seattle flu study specimen starting from January 1. They tested all these specimens and they found 0 case. So they were able to conclude actually our new case started in late February, not in a winter season prior to that. And he was able to go on and propose a hypothesis he calls cryptic transmission, meaning ever since the first patient coming to Providence Hospital who returned from Wuhan on January the 15th, and the later case in February, there was about 5 to 6 weeks of quiet time. And he believed, based on the genetic analysis and DNA mutations, nucleic acid mutations, he thought the virus was spreading in the community quietly. And we just didn't know, and that's why he calls it cryptic transmission. Did this theory turn out to be true? Well, it was not confirmed. Another more comprehensive study published in bioRxiv on May the 21st. The title was The Emergence of SARS-CoV-2 in Europe and in the US. Based on the genetic analysis, they were able to tell the cases we got in the state of Washington came directly from Wuhan and China. And the viral pandemic starting in New York came from Italy. And they were able to analyze by genetic mutations of these viral strains as it evolves. The first case, they called it WA1, actually did not transmit the disease to anybody else. The later Washington state outbreak came from somebody else in parallel. So we need to pat our back for this hospital and the team that took care of this patient. They did a fantastic job. They treated the patient successfully and isolated the patient, and he did not transmit the virus to anybody else. He came to a dead end in the transmission chain. So you can see the power of genomic epidemiology. It really traces how the viral infection spreads, and it's far more powerful than human contact tracing. Another interesting phenomena tracked by the genomic DNA is viral mutation. One mutation is called the D614G. That is the spike protein at amino acid residue number 614 was changed from D, aspartic acid, to glycine to G. And what's the importance of this mutation? There are so many other mutations. Why is this one important? This one has become a global dominant strain. In the mid-February, started in Italy, this strain started showing up. And everywhere this strain went, it became a dominant strain. Why is that? It turned out there are multiple basic science studies showing this mutation causes 10 times higher infection rate. Infectivity is much higher. The disease is not much more severe, but it spreads more easily. And that might explain why we started out as the epicenter in the US, but we did okay here in Washington State because we got the regional D strain from Wuhan, which was not mutated yet. By the time East Coast, New York City got it from Italy, where the dominant strain already took over. So that partially explains why New York was hit so much harder. There was a biological reason. And perhaps it has to do with this D to G mutation. Another interesting genomic epidemiology study took place in Barcelona, Spain. They had the first case in February, late February, very much like Seattle, and it peaked in April and May. They thought, well, can we check the sewage system, because everyone spits and poops into the sewage system, and maybe we can use that as a way to monitor how the epidemic is happening locally. So the first case was reported on February the 25th, but by checking the sewage system for viral particles, they were able to find the virus a month ahead of time. So it's a very powerful tool. I wonder if this tool could be used to monitor schools and prisons. And when kids go back to school, you can monitor the sewage system and see if there's any insidious infection spreading in that school. Not much of that is talked about in the media, though. I'm pretty sure somebody's going to look into that. What's even more interesting in this Barcelona study was that They went back and looked through some frozen samples of the sewage systems from 2018 all the way to the end of 2019. In March of 2019, one single day, they discovered there were SARS-CoV-2 virus present in a sewage system. 2 different genes. They checked 5 different genes. 2 different genes were detected. So what happened on that day? A year ahead of time, this virus was discovered in Barcelona. Was it an animal that was infected? Was it a traveler going through there? Why did it just show up for one day? So it's amazing and fascinating discovery, but this remains a myth. Now let's move on to clinical medicine and see what kind of major discoveries were made. As we know, SARS-CoV-2 infection presents in two groups of patients. You can broadly classify them into asymptomatic and symptomatic, and some of the asymptomatic patients will eventually become symptomatic, so they are reclassified as pre-symptomatic patients with a hindsight. But when they were in the asymptomatic phase, you don't know which way they're going to go. Once they develop symptoms, they go through different stages or phases. The first week or so, it's just symptoms caused by a viral infection directly, and the second week going on forward, there's cytokine storms, ARDS coming in, and then following that, the endotheliitis, hypercoagulable state kicks in, and multi-system thrombotic events might happen. And in a very late stage in the pediatric population, you have the multi-system inflammatory syndrome in children, or MIS-C. Talking about symptoms, perhaps the CDC report of 1.3 million people was the largest single case report. It was published in the Mortality and Morbidity Weekly Report in June. If you look at the ranking of symptoms, it was published in a table, difficult to read, so I plotted out in this graph. It's easier to see. It's a pneumonia. It's a respiratory infection, so it's expected to see fever, cough, and shortness of breath. But if you look at individual symptoms, none of them will be present more than 50% of the time individually, which tells you this is going to be a very diverse symptomatic presentation. And it was, as we talked about in the upper respiratory, we look at the ACE2 gene expression, the receptor expression. It's common in GI tract, so it's not uncommon to see GI symptoms of diarrhea, nausea, vomiting. Somewhere between 8% to 19% individually. If you put them together, they're probably 25% of the patient will have some degree of GI symptoms. And what's interesting is the ACE2 receptor expression is mostly in the lower respiratory system, epitheliums, alveolar cells, and not so much in the upper respiratory. As a result, you don't see as much of the runny nose, nasal congestions, watery eyes, and we normally see with other upper respiratory infection. So the ACE2 expression location really gives us an idea why this disease behaves this way. Now, let's talk about the risk factors that will cause, put the patient at risk for higher mortality. And this data was collected in the last week, 10 days of January from Wuhan in 21 hospitals. There were about 168 patients who died. They were able to plot out the risk factors. If you think it's a pneumonia, you would imagine somebody who has a baseline chronic lung disease will be at higher risk for mortality. Well, that didn't turn out to be the case. It is the hypertension, diabetes that are dominant comorbidities that led to a more severe disease and death. And this just tells you this is a multi-system disease. This is not the pulmonary disease only. The next study, as I see this author from Wuhan, he has really published some landmark studies, and this one I will show you. It's from 2 Wuhan hospitals. Data were collected before January the 31st, and so by then the patients were either discharged or died. So they don't have any ongoing patients in the hospitals. That makes the data analysis much easier to make conclusions. And this chart really shows the time course of the disease So they compared survivors against non-survivors who died and see how their clinical course behaved differently. The first symptom is fever. Of course, a viral infection will cause fever, and typically the fever lasted somewhere between 12 to 13 days. What I couldn't tell from the chart is whether this is a natural course. People typically have fever for 13 days, 12 days, or because around that time patient got sicker and they started using steroids. Around the same time, the steroids masked the fever. And I will probably check with our ID colleagues and see what their experience is if the fever normally just runs its course about 2 weeks, and cough, of course, and display, as you can see here, in the first week, 6 days, no matter in this survival group or non-survival group, shortness of breath was not a major problem until the second week. And patient typically develop sepsis and ARDS between day 9 and day 12. So near the end of second week, that's when they get sicker. And that's when they get moved into the ICU. So the timing to go into the ICU between the survival group and the non-survival group were very similar. And this chart also shows for these severe hospitalized patients, the viral shedding time is fairly long. For the survival group, 20 days, and the non-survival group, about the same. And so by the end of 3 weeks, 21 days, you're either discharged or you didn't make it. So the timing is very important. I would imagine it would be very helpful to document in our daily progress note. This patient is symptom day number 3, day number 7, because that gives us an idea where the patient is heading to. The same study identified a lot of risk factors that are validated subsequently and are highly and are frequently quoted and guiding our treatment. One finding is D-dimer. As you can see from panel A, the blue line is the survival group. The red line is the non-survival group, the non-survivors. The non-survivors had much higher D-dimer levels, and consistently, the survivors had minimally detectable D-dimer level. And lymphocyte lymphopenia was common, typically for the non-survivor group. Absolute lymphocyte is less than 500. And for the survival group, they're consistently over 1,000. So counting the lymphocytes or lymphocyte or neutrophil lymphocyte ratio would be very helpful. And this study also identified IL-6 as a risk factor, and that subsequently led to the usage of tocilizumab for IL-6 cytokine storm treatment. Now, by now we know this is a multi-system disease and has many extrapulmonary manifestations. The main pathophysiology is such: there's a direct viral toxicity, there's the cytokine storm, there's endothelial damage causing vasculature problems and clotting, and the blood pressure regulation problems involving almost all the major systems in the body. And this study was a pathology study. It's not quite autopsy, but it did postmortem biopsies of different body tissues. And this, again, came from Wuhan and published very early on in mid-February in Lancet. It did lung biopsies, left and right lung here shown, and liver and heart. So what they found in a postmortem lung biopsies is mostly hyaline membrane formation, which is a typical ARDS finding, and lymphocytic infiltration. And for the liver, very non-specific findings. Liver damage is common, but typically not very severe. The heart biopsies also showed mononuclear cell infiltration, some inflammatory changes. And they also did flow cytometry of peripheral blood that shows lymphopenia. Both CD4 and CD8 T cell were depleted substantially. as gastroenterologists, we obviously paid a lot of attention to the GI tract, and any COVID-19 literature related to GI is important to us. And this study was published in Lancet GI in March. Again, I think from one of the Chinese cities. They reported the case series of 41 patients. They shown the viral shedding time. The red is respiratory viral shedding. The yellow is GI tract, fecal viral shedding. As you can tell, half of these patients shed the virus in the feces for much longer duration. On an average, they shed the virus in the fecal substance for almost a month, typically about 11 to 12 days longer than the respiratory tract. That's why we gastroenterologists are very cautious about scoping our patients, because when we do EGD, they gag and cough. The respiratory virus might come out in aerosols. And when we do colonoscopy and the GI tract has high ACE2 enzyme receptor expression and very prolonged viral shedding in these patients. And when you do a colonoscopy, you put air in there, they pass gas and lots of aerosols coming out. So there's some arguments in the literature saying, well, the viral shedding in the fecal matters are probably not important because they may be just broken pieces of nucleic acids and they may not be infectious. Well, my argument is that if you can shed the virus for that long, it cannot be simply dead, broken virus, because they should not sustain shedding for that long. It has to be active viral replication. And our suspicion is confirmed by this study published in medRxiv in mid-April. They were able to isolate fecal virus and SARS-CoV-2, and they were able to use that isolate to infect monkey kidney epithelial cells. We know the kidney cells expresses ACE2 receptor, so that cell is a good candidate for study this particular virus. So this basic science study basically confirms that the viral shedding in the fecal matter are live and infectious, not just that virus. Clinically, it's been reported if you do a CT in someone who had GI symptoms, you may find colitis or enteritis, very prominent bowel wall thickening on the CT shown on the left side of the panel. What's interesting is when you do a colonoscopy, they don't actually look that bad, even though it looks horrible on a CT. This study was published fairly early on in March, and the author's conclusion was this was probably direct viral invasion into the GI tract based on the ACE2 receptor distribution there, but it could be vascular thrombotic events. And as shown in this case report, this patient developed portal vein thrombosis. It was published in American Journal of Gastroenterology. So even though the liver involvement is typically mild, but if you throw in portal vein thrombosis, as portal vein blood supplies 2/3 of the circulation blood supply to the liver. So when you cut off that much, and if you got the viral infection involving the liver, you can be in serious trouble. Now, let's move on to talk about thrombotic events. Perhaps this German study was highly publicized in the news media for a good reason. It was published in May from a German hospital. They did 12 cases of a consecutive COVID-19 autopsy. They were able to show that more than half, 58% of the patients had DVT, and about 30% of them had massive P. They determined to be the direct cause of death in these patients. And as we would expect, these group of people have higher rate of viremia. Once the virus gets into the bloodstream, it will attack endothelial cells and cause clotting disorder. Of course, the clotting disorder in this population is very complicated. There were reports about elevated factor, von Willebrand factor. There's phospholipid syndrome. So the etiology is complex, but at least endothelial damage is one of the reasons. They showed vividly some big clots in saddle PE and DVT in this autopsy series. And then instead, in addition to large vessel DVTs and clotting, you can have small vessel ischemia. You can have blue toes with COVID-19 patients. This Dutch study compared inpatients or patients, ICU patients, and they show despite routine thrombotic prophylaxis, DVT and the PE is very common in the floor patients, 10%, in ICU patients up to 60% would develop some kind of venous thrombotic events. The Mount Sinai School of Medicine data recently shows if you do therapeutic dose treatment, the red line, versus prophylactic dose treatment in a critically ill ventilated patient, you can improve 28-day mortality. And if you involve all patients, the benefit is not as much. So anticoagulation seems to be beneficial in a very critically ill patients. Now let's move on to medical therapeutics and what discovery has been made. It's quite controversial to talk about hydroxychloroquine, so I'm going to stay away from that. Let's talk about steroids first. Steroids don't have a good reputation. It's been tried over the years for sepsis and ARDS. They were not very good. And there were specific data for MERS and SARS in the past, influenza and the respiratory syncytial virus. The conclusion based on this Lancet editorial in February is there's no evidence to support corticosteroids use, and we probably should stay away from it. Well, to our surprise, the recovery platform from Oxford University shows if you use dexamethasone 6 milligrams a day, PO or IV, in a mechanically ventilated patient, you can reduce mortality by about 36%, and oxygen supplemented patients by 18%. It does not seem to work for the average patient who is not requiring oxygen supplementation. So a drug that was long dismissed and controversial now all of a sudden turned out to be very useful. 6 milligrams of dexamethasone is typically equivalent for prednisone 40 milligrams, so it's modest dose. How about remdesivir? It was hyped and everywhere in the news media, and there were some investigators leaking information out, and I know the first 9 doctors do believe they work. But if you look at the first clinical trial, randomized trial coming from China, published in late April, in terms of viral load, the control groups and remdesivir group, there were no difference. In terms of clinical improvement, no difference. So there was a disappointment from the first trial. And then there was a multinational study published in the New England Journal of Medicine in late May. It shows an clinical improvement, a shortening of disease duration from an average of 15 days to an average of 11 days. So there is a statistically significant benefit of shortening the disease and making clinical improvement, but there was no improvement of mortality. There was no mortality reduction. So the second drug, no mortality benefit, unlike the dexamethasone. And this drug, of course, is much more expensive and less available. Only a few days later in New England Journal of Medicine, they published a second study trying to look at remdesivir and see how this drug might be beneficial. Because the first study already showed some benefit, they really could not do a placebo control. So there was an open label, a control of using the drug for 5 days versus 10 days. And they did not find any difference in clinical improvements or mortality. So the authors conclude that they could not make any conclusions because they did not see any difference between the two protocols. And what about convalescent plasma? In Ebola, this was the only drug that helps and saves lives. But what about COVID-19? In COVID-19, this study came from China, published in June in JAMA, a good journal. In life-threatening disease population, convalescent plasma really didn't make any difference. It's the severe disease that they show the clinical improvement. So this approach does not seem to save lives, but hopeful to shorten disease and making clinical improvement in the seriously ill but not critically ill patient population. There was a Dutch study subsequently tried to duplicate the data, but only after enrolling 86 patients, they terminated study because they didn't think it's going to make any difference. Now, finally, let's talk about the hope on that immunity and vaccinations. And in a world of vaccination, and typically it takes 10 years to develop, but we have some advantages. Based on the previous SARS study, the spike protein was a good target, so they know which protein to go after. And we have the established technology of inactivated viral vaccine development. The track record is very good for hepatitis A, which was a inactivated viral vaccine, and a polio vaccine, the Salk vaccine was that. So this is a mature technology that can be used, and recombinant DNA, recombinant protein can be used to generate proteins, antigens for vaccination. The good example is hepatitis B, which is recombinant vaccination. Now we have new types of vaccine now, the nucleic acid vaccine, either using a viral such as adenovirus as a vector to deliver the vaccine, or using plasmid DNA as a vector to develop DNA vaccinations. And then we have RNA vaccinations. These are very new technologies that will speed up the development of vaccines. The first human study was published in May, and this is the second phase of the same study from China. They showed a adenovirus vectored SARS-CoV-2 vaccine was quite effective, producing neutralizing antibodies as compared to placebo injection. The University of Oxford clinical trial of their vaccine was published, a combined phase 1 and phase 2 together, was published in Lancet. It was effective, very equivalent to convalescent plasma antibody samples in recovered patients. This vaccine also uses adenovirus as the vector to deliver the vaccine. And then the much hyped NIH and Moderna trial uses mRNA as the brand new way of delivering antigen. What it does, it requires very little medication, 25 micrograms, not even milligrams. The mRNA will go into the host cells, and the host cell machinery will produce the protein of spike protein, and that will generate antibody, which was quite successful in its preliminary study, published in New England Journal of Medicine about a month ago. And this is fresh off the press, published in JAMA yesterday, and from a different Chinese city that use inactivated virus using the same approach of hepatitis A and the Salk polio virus. And they were able to produce neutralizing antibodies of high titers, even from using lower doses. Because this approach traditionally would require an adjuvant. The adjuvant they use is aluminum hydroxide, which is quite interesting. It's basically Maalox. As you know, Maalox is a combination of aluminum hydroxide and magnesium hydroxide. It's quite interesting. They use Maalox type of material for adjuvant, but apparently was effective. Well, that comes to the end of my presentation. To summarize all this massive amount of information, I would say numerous and amazing discoveries have been made, and much is yet to be learned. Rapid testing is needed, and inexpensive, easily available antiviral therapy is needed for early intervention before the cascade of inflammation takes place. And a comprehensive multidisciplinary treatment strategy is needed for severe and late stage patients. And of course, effective and easily accessible vaccine will be perhaps the ultimate answer to prevent pandemic. As a gastroenterologist, I would like to make a proposal. Perhaps somebody should consider given the vaccination already like this, like the polio, because we have such a high viral receptor in the GI tract, and that might make vaccination easier and more acceptable to some kids who don't want shots. Thank you. I push end.
Hey, that's a